Postpartum hemorrhage. It is major obstetric emergency defined as loss of blood more than 500 ml after vaginal delivery or 1000 ml after cesarean section. Okay, it is the most common cause of maternal mortality in India, as well as in the world. Okay, now PPH is of two types. First one is primary and second one is secondary. Primary PPH, it happens within 1 day, that means 24 hours of delivery, whereas the secondary one happens after within 12 weeks. Okay. From more than 1 day to 12 weeks, 24 hours to 12 weeks after delivery. So cause of PPH, that's the important, and how we actually manage them. So just write the risk factors. The risk factors are all chapters, all of the chapters that we have studied, like this is PYQ, all the chapters that we have studied. That is, one PYQ is history of pregnancy induced hypertension, HTN, in current pregnancy. It is a risk factor, not a cause. It is a risk factor, and other than everything else, like age, obese, anemia, maternal factors, all of these are maternal factors. Then I have placental factors, that are placenta previa, vasa previa, placenta previa, vasa previa, abruptio placenta, because of this history of antepartum hemorrhage can all happen. I can have pregnancy related problems like queen pregnancy, fibroid uterus, and everything else, polyhydramnios, every chapter you can imagine. And the last one is prolonged labor and everything else, prolonged labor. These are risk factors. But now let's talk about the causes, and there are some causes of postpartum hemorrhage. This is full of PYQs. So we have 4 causes and 4 of them 4 T's. 4 T. All of them are PYQ. The most common is atonic uterus. So tone, it is atonic uterus. Most common cause overall, and the most common cause in primary PPH as well. Next is trauma to where vaginal perineal tear, uterine tear, perineal tear, uterine tear, everything, cervical tear. Third is thrombin, it is a bleeding disorder. And the fourth one is tissue, that is placenta, retained placental tissue, and it is the most common cause of secondary postpartum hemorrhage. Now we need to treat them. Obviously I have the problem now I have to manage all of them. Let's talk about the treatment. Let's just write. So placental tissue is inside retained, so I have to remove it by what? I can manual removal, or surgical removal. Keep it simple, okay? Next is trauma, uterine trauma, bleeding, everything. There can be a prolapse as well. So I will just do what? Trauma, then suture repair, or uterine repair. Simple. Keep it simple. If there is a bleeding disorder, so fresh frozen plasma will be given. Okay, platelets can be given, many things can be given. Okay, so it is as simple as that. Now comes to atonic uterus and overall management. If I have to write the management for it properly, so I have to start like this. So for that, first I have to resuscitate. The first step is resuscitation. For resuscitation, what we'll do, I will make 2 large bore cannula, collect the blood and do blood grouping, then give crystalloid, blood collect, blood collection, and crystalloid is given. start crystalloid, that is ring lactate, or NS ABC, and again I have to do airway breathing circulation ABC, monitor and maintain, and Foley's catheter. Foley's catheter is given. Now I will do after that per abdominal uterine massage. I will do per abdominal uterine massage to find out what happened. If through the massage I found that tone of uterus is normal, it means rule out atonic pregnancy. It means traumatic may be present, traumatic PPH may happen. So I will do per vaginal exam for traumatic postpartum hemorrhage. But if the tone is absent, decreased, it means atonic pregnancy. Now what I do in atonic pregnancy? I have to do the management of atonic pregnancy will be like this. I will first give 3 things altogether. That is, I will do a uterine massage, bimanual uterine massage. I will give an injection of tranexamic acid, and I will give a uterogenic drug. Uterotonic drug, most preferably that is oxytocin. Okay, here is a PYQ regarding this oxytocin. The T half of this thing is 3 to 5 minutes. It also helps in after pain, causes after pain and milk ejection. So side effect is after pain, and also not side effect, milk ejection. Okay, now if unresponsive, then I will give methyl argometrin, if again unresponsive, if not stop, if not, then I will give carboprost. Okay, it is gold standard for PPH management, PYQ. Okay, and during this whole time I will give misoprostol as an add-on. It is the only tablet form prostaglandin EG2 1 it is PYQ. It is not given, oral, not given per vaginally. It is a PYQ. Now, if this entire system fails, is not responding or unresponsive, then I have to do mechanical compression using Bakri balloon catheter. Bakri balloon catheter. Mechanical compression. Its size is 500 milliliter. It is also a PYQ. Now this thing can work. If it works, then remove after 12 hours to 24 hours. If not works, then I have two things. I have to ligate the vital arteries. If it doesn't work, I have to see vital stable, then ligate uterine artery. Vitals not, if they are not stable, sorry, vitals, if vitals are unstable, then ligate. If vitals are stable, then I can shift to OT. Do some temporary measures like external aorta compression, like this. External aorta compression. We have the fist on the umbilicus and check for femoral pulse. Or military anti-shock garment. Shift to OT. Compress external aorta, and then in the OT I will do a PYQ, that is Lynch suture or base suture on the if this is my uterus, then this will be my suture. Okay. If bleeding continues, if it is still continuous, then I can do uterine artery embolism or devascularization of uterus. Devascularization of uterus. If bleeding still continues, then I have to do hysterectomy. If bleeding still continues, then I will give ছাতা খুলে দেবো ভেতরে, umbrella pack PYQ or parachute pack. This is the entire management of ketonic pregnancy. Okay, now let's talk about some short things for our exam, that is our prof. How to prevent this entire thing? To prevention is better than cure. So prevention of postpartum hemorrhage, we have three things, that is AMTSL, active management of third stage labor. Here we give oxytocin immediately after delivery of baby. Controlled cord traction and uterine massage. Next is a risk factor identification. Big baby, postpartum risk factor are hypertension, that is pregnancy induced hypertension, twin pregnancy, everything, large baby, PPH previous. And last is prophylactic uterotonics. Prophylactic uterotonics. Now complications. Postpartum hemorrhage, obviously shock, as hypovolumic shock, a lot of blood is going out, or cardiovascular collapse, anemia, blood is going out, infection, if massive hemorrhage happened, then DIC, disseminated intravascular coagulation, and obviously to save the life, hysterectomy can be done. So this is the entirety.